Welcome back to the deep dive. It's Monday, January 26th, 2026. And, if you're listening to this, odds are you're on your way into an ED or maybe hiding in the break room trying to...
Trying to inhale a coffee before the next ambulance call comes in.
Exactly. And if you work in emergency medicine in the NHS, you'll know that the ground, well, it shifted under our feet back in November.
It really did. We are talking, of course, about NG253.
The new NICE Guideline.
For suspected sepsis in anyone aged 16 or over. And, calling it an update to the old NG51 feels like a bit of an understatement.
It's more of a fundamental philosophy change, isn't it?
I think so, yeah.
That's exactly what jumped out at me. For the last decade, the mantra has essentially been, time is tissue. It was, suspect sepsis, give the antibiotics, ask questions later, just in case medicine.
But this new guideline seems to be putting the brakes on that reflex.
It is. And for a lot of clinicians, especially those who've trained in the last 10 years, that's going to feel, well, deeply uncomfortable.
Absolutely. We're moving from a safety at all costs model, where we sort of accepted a certain amount of overtreatment to make sure we didn't miss anyone, to a model of precision medicine.
So the headline is, we're trading blanket algorithms for what? Risk-stratified clinical judgment.
That's it, exactly.
Which sounds great in a conference room, but it's a lot harder at 3 a.m. in a crowded resus bay when you've got a waiting room with a 6-hour breach time.
Of course.
So the mission for this deep dive is to turn that 50-page PDF into an operational protocol you can actually use today. We're going to look at the new stratification rules, this thing called the diagnostic pause, which is a huge concept we need to unpack, and the new fluid restrictions.
And we have to talk about the legal weight of this, too, because NG253 doesn't just suggest these changes. It explicitly ties your decision-making to the new WS2 score in a way we just haven't seen before.
Okay, let's start right there with the executive summary. If our listener has to run into a trauma call in 5 minutes, what are the absolute must-knows? What are the headlines?
Okay, 4 big things. If you take nothing else away, take these.
Go on.
First, NWS2 is no longer just a tracking tool. It's now the mandatory risk stratification engine. You can't just clinically eyeball high risk anymore without referencing that score.
Okay, so NEWS2 is the law. What's number 2?
The end of antibiotics. Immediately for everyone. This is the biggest culture shift. We now have explicit permission, in fact, a recommendation, to defer antibiotics in moderate and low-risk groups to get the diagnosis right.
That's the one. That's the one that's going to catch people out, the idea of waiting.
Third is fluid conservatism, the reflex of hanging a 500 milliliter or 1 liter bag and just walking away. That's dead. The new standard bolus unit is 250 milliliters.
A teacup.
A teacup. And fourth, we finally have the green light for peripheral vasopressors outside of ICU, provided, and this is a big asterisk, you follow the safety checks.
Okay, that's a fantastic overview. Let's get into the weeds. I want to start with the basics, clinical recognition and the anatomy of sepsis. The definition itself hasn't changed, has it?
No, the core definition stands. We're still looking for that life-threatening organ dysfunction caused by a dysregulated host response to infection.
That dysregulated response is key, right? It's not just the infection, it's the body injuring itself.
Exactly. But the guideline is very specific about who we should be worried about, the vulnerable populations list.
Most of it is, standard emergency medicine bread and butter.
It is. People aged 75 or over, the frail, the immunocompromised. But there's a very specific window mentioned that I want to flag. Surgery or invasive procedures in the last 6 weeks.
6 weeks? That's a long tail.
It's a really long tail. And it's so easy to miss the connection between a fever today and, a minor procedure a month ago. A dental extraction, a scope. You have to ask the question explicitly.
The other massive emphasis in the documentation is on communication barriers.
This is huge. The guideline highlights people with learning disabilities, neurodiversity, or language barriers. The logic is simple. Sepsis is often picked up via soft signs.
Right. If a patient can't tell you they feel wrong or doomed, you lose that early warning system.
You do. So in those populations, your index of suspicion has to be, through the roof.
And speaking of soft signs, the guideline puts a lot of weight on the history, specifically concern expressed by family or carers.
It really does. It validates carer concern as a proper clinical red flag. If a wife says he's just not himself, even if the physiology looks okay, you treat that as a high-risk indicator. The source material is so clear that behavioral changes often precede physiological ones.
And on physiology, there's a warning about temperature that I think is worth repeating. We're so programmed to look for the spike, aren't we? We want to see 39 degrees to feel validated.
Correct. And that is a dangerous bias. The guideline explicitly says, do not be reassured by normal temperature. In the elderly or frail, normothermia or even hypothermia is actually a really sinister sign.
It suggests the immune system just isn't mounting a response.
Precisely. If they're cold and mottled, but the thermometer says 36.5, you trust your eyes, not the machine.
That brings us neatly to the engine room of this guideline, assessment and stratification. You said new WS2 is king. How rigid is this? Can I still use my gut feeling?
You can use your gut to upgrade risk, but you can't use it to ignore the score. New WS2 is mandatory for adults over 16 who aren't pregnant. You need to bucket your patient into one of the bands immediately.
And that determines everything that happens next.
Everything.
Let's start with the one we all know, high risk.
So that's the easy one, a NWS2 score of 7 or above. If they score a 7, they are high risk. You treat, but, and this is a critical nuance that will trip people up, you can be high risk with a score of 5 or 6 if a single parameter is scoring a 3.
Okay, let's play that out because this is where the confusion happens. I have a patient. Let's say their respiratory rate is 26. That gives them a 3. Their total score is 5. By the old logic, I might just watch them. By the new logic.
By the new logic, they are potentially high risk. But the guideline requires a clinical check.
Yeah.
It asks, is that score of 3 due to the infection?
Right. So let's swap the patient. I have a COPD patient who lives at 88% SATs. They score a 3 on oxygen baseline every day of the week. They come in with UTI.
Exactly. If you follow the algorithm blindly, you'd call that COPD patient high-risk sepsis just because of their baseline SATs. The guideline demands you ask, is this new physiology or is this old physiology?
So if that single 3 is chronic, I can downgrade them to moderate risk.
You can, but this is where the doctor starts and the robot stops.
Yeah.
You have to document that decision, though. Score of 3 due to chronic COPD, not acute sepsis.
And there's a visual override, too, isn't there? You said trusting your eyes.
Yes. Even if the new WS2 is 0 perfect numbers, if you see mottled or ashen skin, cyanosis, or a non-blanching petechial rash, the score is irrelevant. They are high risk. Do not pass go.
So we've got high risk. What defines moderate?
Moderate is an NWS2 of 5 or 6 without that single parameter kicker we just discussed.
And low risk?
NWS2 of 1 to 4. Very low is 0 to 6.
Okay, so this stratification sets up everything. Let's talk investigation. We've stratified them, now we work them up. The guideline uses an adapted sepsis 6 approach, doesn't it?
It does. A, B, C, D, E. And in the immediate actions list, 2 things really stand out. First, the blood gas. We're obviously checking glucose, but we are hunting for the lactate.
Your hidden hypoperfusion meter.
That's it. And the second thing, blood cultures. The guideline is emphatic. Take them before you give antibiotics.
Before is a heavy word in a busy ED when you have a nurse standing there with the syringe ready to go.
It is the ideal, yeah. And the guideline acknowledges reality. It says don't delay if the patient is crashing. But for most, that diagnostic yield matters. Once those antibiotics are in, your chance of growing the bug just plummets.
Then you've got your standard panel, FDC, CRP, OSNS, clotting, nothing new there. But there was a note on source control that felt a bit more directive.
Yes, consider urine and chest x-ray for everyone. The logic is they're the 2 most common sources. Unless the source is glaringly obvious, like a horrendous cellulitis, you should probably be screening the chest and urine.
And if those are empty?
You move to imaging the abdomen and pelvis. Don't just guess.
And we have to give a nod to our surgical colleagues here.
Crucially, do not sit on a surgical source. If you suspect an obstruction, a perforation, an abscess, you involve the surgical team immediately. Antibiotics can't drain an abscess. Source control is just as important as the drugs.
Right. Let's get to the part that changes practice. Section 4, treatment protocols. This is where the stratification determines the timeline. Let's do high-risk pathway first, the golden hour.
This hasn't changed much, but it's tighter. If they're high risk, so a new WS2 of 7 or more visual red flags, or that single parameter 3 due to infection, the clock starts ticking.
What does the clock demand?
An urgent assessment by an FY2 or above,
Oh, God.
and broad-spectrum IV antibiotics within 1 hour of the score being calculated.
Not 1 hour from when the doctor sees them.
No. 1 hour from the OBS being taken.
That is a very tight window.
It is. It forces a code sepsis mentality. You also need a senior clinical decision maker in ST3 or above involved ASAP. This is full court press, fluids, drugs, senior review.
Okay. Now let's pivot to the moderate risk pathway. This is where the guideline introduces the diagnostic pause. This is the part I really want to drill down on.
Okay, let's paint the picture. You have a patient, new WS2 is 5, they're febrile, maybe a bit tachycardic, but they're alert, chatting to you, perfusing well. Old guideline. You'd probably just start antibiotics, be safe.
Right. Sepsis 6, give the meds.
The new guideline. You are advised to consider deferring broad-spectrum antibiotics.
Deferring?
For up to 3 hours.
3 hours? I mean, that feels like a lifetime when you've been trained to view sepsis as a ticking bomb. Why are we doing this?
It's about antimicrobial stewardship and diagnostic accuracy. We're trying to stop blasting people with things like tazocin for what might be a viral illness. The guideline is saying use that 3 hours. Get the x-ray, dip the urine, wait for the white cell count.
But there have to be safety rails on this, right? We aren't just parking them in the waiting room.
Huge safety rails.
Right.
Firstly, if you identify the source and decide they need treatment, you treat immediately. You don't wait 3 hours just because you can.
And the second rail.
This is critical. If there is any evidence of hypoperfusion, the pause is canceled.
Define hypoperfusion in this context.
Lactate greater than 2 mmol or any evidence of an acute kidney injury. If your moderate risk patient has a lactate of 2.5, even if they look okay, they are effectively high risk. You treat now.
So it's Michelatin. New WS2 is moderate, lactate is low, you have time to think. New WS2 is moderate, lactate is high, you treat.
Exactly. And for the low-risk group, the logic is similar, but you have a longer leash. You can defer for up to 6 hours.
Before we move off antibiotics, I noticed a specific call out for the 16 to 18-year-old demographic.
Yes, specifically for suspected community-acquired sepsis.
Yeah.
The first line is ceftriaxone 80 millinanokilogram once daily. Max dose of 4G.
That's a deviation from the standard adult protocols in a lot of trusts?
It is. It aligns more with the pediatric meningitis protocol. So if you have a 17-year-old coming in, don't just autopilot to the adult sepsis cupboard. Check the guideline.
Let's move to Section 5, fluids and vasopressors. You called it the teacup rule. The days of give a liter and see what happens are over.
Completely. We now know that iatrogenic fluid overload, saltwater drowning, worsens outcomes. It causes tissue edema, lung edema. So the guideline is enforcing fluid conservatism.
What's the protocol?
Fluid choice is an isotonic crystalloid, so Hartmann's is preferred. And the bolus is 250 milliliters.
That's going to be a hard sell operationally.
Right.
You ask a nurse to hang 250 milliliters, they'll look at you like you're crazy.
It requires a culture change. And the operational burden is the reassessment. You give 250 milliliters over 10 minutes. Then you must reassess. BP, heart rate, cap refill, still dry, give another 250, reassess.
It sounds like a lot more work.
It is more work. It's much easier to hang a liter and walk away. But this is safer for the patient.
And is there a hard stop?
There's a hard stop at 1,000 milliliters. If you poured a liter of fluid into a patient and they are still hypotensive, the guideline says, stop. Call the senior clinical decision maker. Do not just hang another bag.
Which leads us directly to vasopressors. This used to be ICU territory, but NG253 seems to be democratizing vasoconstriction.
It's a pragmatic shift, isn't it? We all know the bottleneck. You have a fluid refractory patient, but there are no ICU beds. The guideline explicitly permits peripheral administration of vasopressors, usually noradrenaline, if central access is delayed.
But this isn't set and forget. You can't just put it through a small cannula in the hand.
God, no. You need a large visible vein, ideally in the ACF. And you need regular monitoring for extravasation, because if that leaks, you get tissue necrosis. But operationally, this is huge. It lets us stabilize the MAP and the ED while we wait for a central line.
Okay, so we've managed the acute phase. Let's talk about the two exit routes. Complications and discharge. What defines failure to respond?
The guideline is quite specific. It's defined as worsening tachycardia, hypotension, rising lactate, or a dropping GCS.
And if we see that,
Immediate senior and ICU involvement. The guideline basically says, do not sit on these patients in the bay hoping the next bag of fluids will fix it. Escalate.
and what about the other exit route, the low-risk patients who turn out to just have a viral flu?
Safety netting. And I know everyone nods and says, yeah, safety netting. But the guideline makes this a formal structured requirement. You cannot just say come back if you get worse.
So what do we need to provide?
Verbal and written information. You need to explain what sepsis is, why you were worried about it, what specific symptoms to watch for, and exactly how to access urgent help.
And there's a crucial admin point regarding the GP, isn't there?
Yes. If you diagnose sepsis, the discharge notification to the GP must state sepsis.
Why does that matter so much?
Because it goes on their permanent record. A history of sepsis puts them in a higher risk category for the future. If you just write chest infection, that data point is lost. and the next clinician loses a piece of the puzzle.
So let's zoom out. We've gone through the bands, the pause, the teacup fluids. If you had to summarize the philosophical shift for the doctor listening right now, what is it?
It's a shift from defensive medicine to precision medicine. The guideline is trusting us. It's trusting the senior clinician to use new WS2 intelligently, to interpret that single parameter 3, and to use the time bought by stability to make a better diagnosis.
It strikes me that the most provocative part of this is that diagnostic pause. It's asking a lot of a clinician's nerve.
It is. It feels safer to prescribe. Writing the chart feels like doing something. Sitting on your hands for 3 hours while a patient has a fever feels passive and risky. But the evidence says that if they're stable, indiscriminate antibiotics are not harmless.
They breed resistance, they cause C. diff.
They mask the real pathology. The challenge for you, for the listener, is, are you confident enough in your assessment to hold your nerve for 3 hours to get the right answer?
That's the question. And a final practical tip before we sign off.
Go and read your local antimicrobial formulary. With these changes in timing and the ceftriaxone note for teenagers, your local trust has almost certainly updated what you should be prescribing, not just when. The sepsis box in your treatment room might have different drugs in it next week.
As always, we've linked the full NICE NG253 guideline in the show notes for you to read on your break if you ever get one.
Good luck on your next shift. Stay precise.
Stay safe. Thanks for listening to The Deep Dive.